Thank you so much. Welcome, everyone. A special thank you to our invited guest, Dr. Allegra Cummings and Dr. Renatta Ferdinand, and also to their special guest who may be joining us. Before we hand it over to our peer leaders today, we just want to let you know a little bit about this Black Maternal Health Initiative. This initiative began as a student-centered project. BMHI is a student engagement, community engagement project. In December 2001, a small group of students, alumni, staff, faculty, in a small library roundtable, sort of like this one, expressed a sense of real urgency about having a larger MCNY conversation on this topic and doing more advocacy on this topic. So the librarians were inspired to find a way to support that vision. And so hence this project. So the focus is really on the inequities that underpin the Black maternal health crisis. And I want to say over the semester, it's really been a complete privilege to witness how our peer leaders have grown, how, they've immersed themselves in thinking and researching, discussing on this topic. And this talk is called, we're calling it a teach-in in the spirit of that learning, sort of sharing mentality. That's our focus. So thank you again for joining. And my colleague, Tina Callender, will say a few words now.
Good evening, all. I'm Tina Callender. I'm the Evening Reference Librarian here at MCNY, and I want to thank the panelists and our viewers for joining us this evening. And I'm hoping for a wonderful, spirited conversation, teaching, learning experience, all those good words about reproductive justice. Kate?
Hi, I'm Kate, and I'm the director of the library, and I'm going to talk again, as I did in the last roundtable, just a bit about the question of why are we doing this in the library? What's the connection between the library and this topic? It's a good question. The connection might not seem so obvious to you guys, but it was to us. Baked into the very notion of the library is that access to space and ideas and information is a human right, and that we should all work collectively. We should pool our resources, we should share them. And that's very much in the spirit of what we're talking about today, I think. And we can think about the urgency that sharing information and resources really has sometimes. At our library and in this project, we draw on a tradition called participatory action research. It's a specific thing. We draw on it loosely, informally. But we like that it recognizes that information is more than just a right. Information is power. According to the Highlander Research and Education Center, I like this quotation, and I think about it when I think about the way we think about research, and specifically this project. PAR, Participatory Action Research, that is, puts that power in the hands of people seeking to overcome problems in their daily lives. It is a collective process of investigation, empowerment, and action. The people most affected by problems investigate them, analyze the issues, and ultimately act together to bring about meaningful long-term solutions. I think that's, at least aspirationally, and really we're moving towards that. Our peer leaders is a good way to frame what the goals of the orientation of this kind of project. It's an idea that's at the heart of MCNY and our sort of idiosyncratic purpose-centered education. It's at the heart of our library. It's at the heart of this project. And it's a good segue to turn this over to our peer leaders. Lorna is starting.
Pleasant good evening again to everyone. And my name is Lorna Modest Thomas, an alumni of MCNY, also a peer group leader and a community health educator. At this point, I would like to welcome our guest panelists, Dr. Renatta Ferdinand and Dr. Allegra Cummings. I would like to also go through a few rules and engagement as it relates to this evening roundtable. Back in the chat, there is no dumb question. Speak, voice your voice, respect the time. We have a timekeeper. The timekeeper will give you a buzz if you go over your time. Please be respectful of each other's time. Our timekeeper, no other than Paige, is here with us today. These topics are heated topics. Please be respectful of each other's opinions, feelings, and experiences. At this point, I would like to welcome Wilhelmina. Thank you.
Thank you very much, Luna. Hi, everyone. My name is Wilhelmina Warriet. I'm a current student at MCNY. I'm in the Healthcare Administration Management degree program. So today I'm gonna welcome Dr. Allegra Cummings. Dr. Allegra Cummings is a board-certified obstetrician and a gynecologist. She received both her degrees in MCNY, graduating with her BA from Barnard College, Columbia University, and her medical degree from Albert Einstein College of Medicine in the Bronx. Dr. Cummings has 20 years of experience as the practicing OBGYN practice in the NYC and many years of experience and honors as a professor of medical education. Dr. Cummings has a special interest in supporting women who chooses vaginal birth after cesarean section, an issue that we have learned is very important to Black maternity health, as Black birthing people are more likely to have C-section, and C-section carry significant risks. We are very happy to welcome Dr. Cummings this evening and invite her to please say a few words about how the personal, political, and professional comes together for her in her work and journey. Thank you, that's the end. Thank you, Dr. Cummings.
Thank you so much, Wilhelmina, for that lovely introduction. And hello, everyone. I'm Dr. Allegra Cummings. I have, just like Wilhelmina said, I have been an OBGYN doctor here in New York City for, I've been in practice for just over 20 years. I think that kind of the healthcare justice and justice for, Black and brown birthing people really is obviously it's personal, it's personal for all of us. I have worked in Upper Manhattan and enjoyed having a practice that is a beautiful combination of people. I have worked with people from all different insurance pools. I have worked in education, and as it has come to light over these past 20 years of my career, you very clearly there is a disparity. We know this, the numbers have been tabulated, birthing Black people and people of color have a 3 to 4 times higher risk of dying in childbirth. Now we have the situation where Roe v. Wade has been overturned, and we know that this is going to begin to affect all birthing people, and it will affect everyone, but we are obviously very worried it's going to affect our communities of color more. I've done research and tried to, with my colleagues, participate in activities and committees and projects to try to help decrease the gap, basically. And I think that the beginning of doing that is, knowledge is power, is to really start looking at it and see what solutions we can find. So I'm looking forward to talking with the whole group about what I know and how we can all try to make this a more health equity positive place.
Thank you very much, Dr. Allegra Cummings. At this point, I would like to invite Michelle.
Good evening again. My name is Michelle, and I will, at this time, I would like to introduce to some and present to others Dr. Renatta Ferdinand. Dr. Renatta Ferdinand is the chair of the Department of African American Studies at New York City College of Technology, CUNY. She earned her undergraduate degree at Fort Valley State University and her doctorate in communication studies with a concentration in African diasporal studies at Bowling Green University. Dr. Ferdinand's scholarship includes Black motherhood studies, Black girlhood studies, and now this word, I don't know if I'm gonna pronounce it right,
autoethnography.
I still can't pronounce it, but it is. And
But you love that word, Michelle.
and a narrative writing. In 2022, she published her first full-length study of its kind, an you know the word, of African-American motherhood. It's called Things I Tell My Daughter, an interdisciplinary work grounded in Black feminist theory. And that is Dr. Ferdinand.
Thank you so much for that introduction. And thank you everyone for joining us today. I know it's 5 o'clock on a Monday, but this is such an important topic that I think everyone should be concerned about. So like Michelle said, I'm the chair of African American Studies at New York City College of Technology. I'm also an associate professor. My research looks at Black motherhood and also Black girlhood. And so I, in a way, combine those to kind of look at the issues that affect Black girlhood, also the issues that affect Black motherhood. So I'm just glad to be here today to talk with you more about this.
Paige. Thank you.
I guess I was going to talk about wrapping up the two speakers. My question for Dr. Cummings. What is the or do you worry about the Roe versus Wade helping a woman making a decision to either keep a child or to abort? What do you think the consequences can be for you helping a woman in that situation?
Thank you so much for that question. And I think that that's kind of one of the central questions that, even though we are, we're in New York, we're in a state where we still have the right of birthing people to control our bodies, and that abortion is an option to birthing people. It is definitely, anytime a patient is in a situation where they're deciding to terminate a pregnancy, either because of an anomaly, like there's something wrong, or maybe the pregnancy didn't grow and it's a miscarriage that didn't come out yet, or maybe it's just not the right time for them. It is always an extremely personal and difficult decision. I think that's one thing that maybe people who've never been in that situation can't imagine. They can't understand how it would happen. I think that the hard thing is that there's an article that the New York Times put out, kind of literally showing us in stark reality where in this country abortion is now illegal. So it was very eye-opening to me. There are about 20 states where New York is one of them, where abortion is still legal and nothing has changed. There are probably about 9 states where it's absolutely illegal, and then another 6 where we are pretty sure it's going to fall, and then a whole lot of gray in between that. And we've already begun, my colleagues and I, to face questions and I was at work and there was a patient who had come in from a different state to avail herself of our family planning services. There was another patient I took care of who was very sick and had a very, very involved miscarriage. And that patient had just traveled from a state where abortion was illegal. And it was a situation where had she stayed in that state, and she was just visiting and, you know, nothing was weird, and she just had a very tragic outcome to her pregnancy, but had she stayed in that state, I'm not even sure she would be alive right now. So it's just stunning. And I think that, you know, one of the other things it's hard is that we know that this is going to fall disproportionately on communities of color in terms of people being able to do a workaround and say, I live in Texas, I have a fetus that has a lethal problem and is not going to survive, and I don't want to carry the pregnancy to term, but, you know, I don't have the means to go out of state and handle this, versus somebody else in that same situation who's like, I'm going to call my friend in New York and I'm going to get this taken care of. So we're beginning, it's just starting to, the dam is starting to break, I think, in terms of us, unfortunately, really finding out what are the implications of the overturning of Roe v. Wade.
Thank you, Dr. Cummings. Dr. Renatta, do you want to respond?
Yes, I can respond too. And I just want to also say that, you know, the reproductive justice movement is actually more than abortion, and more than, you know, the pro-choice and anti-abortion kind of rhetoric. You know, the reproductive justice movement is holistically looking at a woman's rights, right? So when we think about the definition that you can find online from Sister Song, reproductive justice is the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. So when we look at it from that perspective, you know, this whole reproductive justice movement in a holistic approach is taking all of those factors into account. So not just the abortion and Roe v. Wade discussion that's happening now, it's everything. It's all the choices that a woman has available to her. What are the choices that a woman has access to, right? Because access is a huge thing, right? And so when we think about these communities that these Black women are coming from, a lot of them are coming from sometimes low-income communities, right? Communities that are plagued by, you know, drug infestation, all kind of problems that could affect her access to something. And so when we look at it from that perspective, we always have to keep in mind, you know, the larger systems and the larger ways that this is affecting Black women.
Thank you, Dr. Oh, go ahead. I'm sorry. Go ahead.
Okay, so I have a question, and both Dr. Renatta and Dr. Cummings, feel free to weigh in. How does the overturning of the Roe versus Wade impact Black maternal health, understood in terms of social determinants of health and weathering, and how can the reproductive justice framework help address those negative impacts? Thank you.
Dr. Ferdinand, do you want to go first or should I go?
You can go, that's fine. Yeah, you can go first.
So I want to also say that what Dr. Ferdinand, I completely agree, echo it. You know, we think that it just is starting with abortion. It ripples out to all of healthcare for, you know, women and birthing people in term, you know, when we're talking about access to healthcare and, you know, access to choice, you know, autonomy, could not agree more with all of that. So I think that there's a couple of interesting things when we talk about weathering. It's something that I've done, you know, like I said, like a lot of us, been looking into this question of why are we having such higher mortality and morbidity? Not just for every one woman that dies, there's 100 near misses or people had terrible complications. And why is this happening? So this concept of weathering is the notion that a group of people who are living in a higher stress environment, who have a higher likelihood of a poor socioeconomic situation, have a higher likelihood of actually just being you know, not being able to access care, of being treated in a racist or a biased way, living in this permanent, perpetual kind of a stressful environment has been literally shown to create sicker us's, so that you've got an increased risk of diabetes if you're a Black person. If you've got an increased risk of hypertension, you're going to have an increased risk that these conditions have progressed further, and then you're putting that into the soup of maternal morbidity and mortality, and of course the numbers are going to be not as good. So that's where the weathering kind of has an effect, you know. And then again, as we're saying, the problem when you overturn a big law like Roe v. Wade, it is not just simply a person who decides they want to discontinue their pregnancy can't do it. It has a ripple effect into everything. It has an effect of, you know, people who are coming in who have a pregnancy that stopped growing and there's no heartbeat. The doctor can't actively manage them. There's a higher chance that lady's going to get an infection. There's a higher chance that lady's going to bleed. The patient that I took care of this weekend that had an extremely dramatic miscarriage, had she been in the wrong state, probably could have bled to death. So I think that it just, what's frightening about all of this is I feel like we're on the precipice of things not getting better. You know, we're really all going to have to work to try to figure out how we attack this, because it's one thing to be in your state where things are still quote unquote fine. It's not going to work that way, because our resources are eventually going to become stretched. Our ability to help the people who are coming to us, and we all have relatives that live in other states. You know, I have a sister-in-law who lives in Texas, and I'm now afraid to, you know, have my transgender child come and visit because I don't know what's going to happen when we get there. So it affects us, and it's a very huge ripple effect.
Thank you very much, Dr. Cummings.
I agree. And I think because of the nature of my research, which is autoethnography, and I'm going to give you a definition of autoethnography. Michelle, it's actually not as complicated as the word makes it sound. But autoethnography is telling a story, right? And so I fear that with the reversal of Roe v. Wade, we won't hear Black women's stories anymore, right? And that's the thing that I really try to push forward. But just a formal definition of autoethnography is setting a scene, telling a story, weaving intricate connections among life and art, experience and theory, evocation and explanation, and then letting it go, hoping for readers who will bring the same careful attention to your words in the context of their own lives. So through autoethnography, you know, we tell these stories, right? And that's one of the things that activists of the reproductive justice movement, they have relied on stories, right? You got to put a face to these statistics. You know, you bring it home for a person. And so when we use these narratives, right, it connects different women's stories across time and space. And so I think my fear with Roe v. Wade reversal, like what Dr. Cummings was saying, in addition to that, is that we'll lose the stories, and we need those stories, because otherwise, if we don't tell our stories, someone else will. And so when we understand that when Black women tell their stories, they are the experts, right? We don't need anyone else to tell us what our story is. Well, we're already the experts. And if we don't have those stories, we're going to lose that. So I think that's my biggest fear.
Mm.
Thank you very much, Dr. Ferdinand. And I just wanted to make a quick comment on, you made a point, and I think it's very significant, where you stated that Black women should be the one telling their stories. I think that is so significant, because if another person tells the story, it's not going to be authentic. So I just wanted to, you know, just highlight that. I think that point is a very crucial point that you just made. So thank you very much for that.
Exactly. Thank you.
You're welcome. Okay, if there is any members of the audience who would like to ask a question, maybe to Dr. Ferdinand or Dr. Cummings, the floor is now open for you to do so.
Okay. Hi, everyone. I'm Janine Francis. I just wanted to assert for the audience, there is a document, well, it says it's a movie called Aftershock on Hulu right now concerning what we're all speaking about. So I think it's very significant. I tried to watch it and only got through part of it, but it was pretty tearful in the beginning. But I think it's very important as to add into the conversation right now.
I would like to bring up something that Dr. Cummings had said something about because I'm big in the on the trans community, especially the trans men. No, and I want to ask the question like, have you ever, are your colleagues, have you ever came across of someone who don't feel comfortable actually giving birth as they transfer into a man?
Thank you. That is such a terrific question. So I think that it's a little, what I will say is I do have some experience. I have a few trans men in my practice and was very proud to be able to deliver, was actually able to do my patient's delivery, and he did great. I think that certainly, I think that it's a hard, a lot of people come in different points in their journey, you know what I mean? And I think that being a pregnant person as a trans man, I was for the person I'm thinking of, it was challenging for him, you know? I think that what made it better was that we were all supportive, and I think the institutions make a big difference as well. At the time I'm currently at Weill Cornell Medicine. At the time I was at Mount Sinai, and they happen to be really well known for working with trans patients. And we did our best to just make him feel comfortable and get access to information. I think it's always about, you know, saying when you don't know, you know what I mean? Like, it's an emerging, you know, field to be able to help a trans man birth a child. And there's a lot that we don't know, but I think that, you know, by leveling with your patient and being honest and saying, listen, there's some questions that I don't have answers to, but we're going to work together to figure it out. You know, I think that it's a great thing that we have that ability. And I would hope that every state in our country would be able to do that. But that's, again, I feel like these things are beginning to run in parallel, the trying to limit the autonomy of birthing people to, you know, to have abortion if they need it, the limiting of being able to help a child or a young person transition when it's appropriate, when the doctors and the family think it's time. That's not a decision that should be made by the outside. That's a very personal decision that should be made by the person and the family and the healthcare provider. So all of this is connected, trying to make sure that we have the rights just to, you know, be safe, be healthy, live our best lives and live our truths and have autonomy.
Thank you very much, Dr. Cummings. Dr. Ferdinand, do you have any comments on that?
No, I don't think so.
Okay, then, thank you.
I have a question.
Go right ahead, thank you.
So this is for Dr. Ferdinand. I was reading your autoethnography, how you pronounce it again?
Ethnography?
Autoethnography.
Ethnography, yes.
Ethnography, got it. So in reading it, it really, I seen the passion in it. It was so much that you said in it that kind of ignited me. And you mentioned that you had trouble finding your voice due to the upbringing of and religious in your southern family and the academic training. You also mentioned that you pretended to be something that you wasn't, but you got to the point where you was like, you know what? And I'm just saying this how I feel it from your story, that you was like, you know what, forget about what people think. You know, I'm coming out of the box. This is how I feel. This is who I am. I'm a feminist, and this is what it is. How did you feel coming out of that box?
Oh, it was scary coming out of that box. It was really scary, you know, because, you know, you have these expectations that people place on you, you know, whether it's your family or colleagues, and, you know, it comes with a risk when you come out of the box, right? Or even using autoethnography is a risky method to use. It's not widely used because you're revealing personal things about yourself. And so, and it puts people in a position to judge you, right? So it was scary coming out of that box. I actually, you know, had to write the book has like 3 iterations of it. It's like the first draft of it, and then it wasn't true to my voice. So I had to go through a process of actually finding my voice to even write it. And that took about 3 or 4 times to do that. So it was very scary coming out of the box. But now that I'm out, I'm free.
Right.
So well worth it.
What was the challenge in the beginning of writing your book, the book as a Black feminist? Like, what was the most challenging time for you?
I didn't want to say certain things. So, you know, when there are, in the first iteration, there are stories that I tell that are incomplete because I didn't want to say certain things. I didn't want people to judge me. I didn't want people to think I was a bad mother. Like all of that. I didn't want people to think I was a bad daughter. So I struggled with that in the first iteration. I think in the second iteration of it, I added to some of the stories that I had in the first, but I didn't go in depth in them because then they started becoming painful because I was reliving things that had happened to me that I tried to push back in the back of my head. So there were a lot of painful memories. And then I think revealing personal information about people that were in my circle. Like, so the book is like an intergenerational tale. It tells things about my grandmother, my mother, my daughter. And during the process of this, I would get information from them, like just talking about like, what was your childhood like? I would ask my mother, and then I would put it in a book. And so I kind of had this struggle initially with telling someone else's business, because you have to ask, like, who owns the story? Even when you're in it, who owns it? And so I struggled with that in the beginning.
And like you said, you're free now.
I'm free now.
So my last question would be, I mean, it's so much, but I'm gonna make this my last question. What was different from your experience back in 2007 when giving birth, and now as a Black mother of a young Black teenager? Like, what's your experience from back then and now, especially with the pressure of our Black girls?
Yeah, I think in 2007, I knew nothing. And I thought I did. And I realized later that, oh, you don't know what you think you know. I think it was, and I tell a story in the book about my whole birthing experience and how traumatic that was, because I had already studied all of these things about Black women. I knew all the research about Black women dying in childbirth. And I talk about my whole experience there. I think when I first became a mother, I tried to live up to expectations that were not my own, right? So, and I had that kind of familiar pressure. You know, this is how you raise a child. This is how you should raise a Black daughter, and things like that. And so I think in the first couple of years, I struggled to find my voice as a mother. And so there were instances where I just didn't know. I didn't know the answer to a lot of things. And it was like I was just gliding through life, taking other people's advice, taking advice from my mother, and things like that. So I realized then that, oh, I don't know anything. And then as I became more comfortable with who I was as a mother, my mothering, I think, strategy started to change. But by that time, I think my daughter might have been 5 or 6 years old. So she had a version of me when she was younger. And then there was suddenly a newer version of me around when she was about 5 or 6. And that's actually when I started getting heavily into autoethnography. I started really telling the stories then. So I think that kind of happened. And then as she got older, it was like we both grew together. She got older and I got older in my motherhood. I understood what was important to me. So that kind of took me years to develop that.
Do you share with her now your experience coming up and practicing being a feminist?
Yes, she's so tired of me talking about all kind of things. I share everything. She read the book, and every draft of it, I would give to her and ask her to read it. And I ask her, what do you think? And the thing about it, and I talk about this in the conclusion of the book, that her memory of things that happen is so totally different from my memory of things that happen. So when she read the book, she was like, I don't remember this happening like this, you know, things like that. So, and that's the risk you run when you're telling a story. There are multiple ways of telling a story, right? So many different vantage points. And so, yeah, I share all of that with her. I think it has shaped her in a way because she's like a feminist now. And so our latest conflict, you know, now that she's a teenager, is that she thinks she knows everything. And then so we go back and forth what she knows and what I know. So that's kind of like our latest conflict.
Okay. Is she familiar with the Roe and Wade situation?
Yeah, she has some strong feelings about that.
Okay.
And we talked about that. Yes. So we try to stay abreast on all the issues that could possibly affect her, because they will affect her.
Right.
And I just want her to know what her choices are, but I also want her to have access to these choices.
Right. Especially at her young age.
Yes.
And the peer pressure.
Yes.
Yeah. Okay, great. Thank you so much.
You're welcome.
There's a question for Dr. Cummings. Miss Cecilia, she said she has a little bit distraction in the background. So how many Black patients have you had, and what were the birth outcomes? And do you often see the defects in older Black women or younger Black women? That was her question to Dr. Cummings.
Okay, thank you. So I definitely would not be able to, like I said, I've been doing this for about 20 years, and I probably deliver about 150 patients a year. So I definitely wouldn't be able to count up, but it is New York City. So I can say with confidence that I've delivered many, you know, Black patients, you know, people of color. What I would say, I hope, and I don't know that I have actually gone back and like run the numbers. What I would say is that I've been lucky, and I feel like my patients have been lucky that my practice has had my patients delivering in hospitals that are that they're good hospitals, they're quality hospitals where there is there's all kinds of checks and balances to make sure that the patients are taken care of. For example, at Cornell, I sit on a committee it's a Health Equity Alliance committee, where and there's so many things that go on at Cornell that are really good for patients, that are continuing to try to make sure that people are treated fairly, equitably, that the outcomes are good for everybody. So in addition to this HEAL committee that I sit on and a bunch of us are on, where we go through cases, if any nurse or provider or a patient has sent in a note that says, I feel like I wasn't treated fairly, we go over these cases and we try to examine it, not from a punitive standpoint per se, but from a learning, like, how can we do better? How can we make sure that that lady, you know, feels like she's been treated equitably? The second thing that we do to try to, and this is also again, in the part of the conversation where we're thinking it can't all be doom and gloom, somewhere we've got to start coming up with solutions, are things that we are beginning to do in healthcare to try to make equitable decisions for everybody. And these are, and it's kind of boring almost to talk about, but it's basically protocols where we treat every obstetrical emergency the same way. So primarily when I'm at the hospital, I'm delivering babies is like 90% of my job. And then in the office, I take care of all kinds of, regular GYN things, from pap smears to breast exams to birth control and prenatal care. But I think that where we can make the most impact is in the hospital, where you've got typical emergencies, bleeding, severe blood pressure, other complications, to have set protocols. And that's something that not just Cornell, but hundreds of hospitals across the country are beginning to have set ways to approach these problems, so that we can make sure that everybody is treated properly. And it works. Like, you actually see research where if you deal with this particular problem the same way every single time, that stops the BS of the person looking at the Black lady and saying, oh, I don't believe her. Like, it doesn't matter. You're taking a situation that's a clinical situation, and you're approaching it the same way every time. That's how we begin, I think, to kind of get ourselves out of this situation. That's one of the ways that we can do it.
Thank you.
Christopher Jackson, I see you have your hand up. I'm sorry. Christopher have been very patient, so I would like to call on him at this moment.
Okay, so I don't necessarily have a question. I just have two, three comments to make here. And I just want to connect 2 points. One, in terms of autoethnography, and also in terms of the subject for this discussion. It's important to remember, as Dr. Ferdinand stated, that autoethnography is all about storytelling. And of course, the history of storytelling when it comes to Black women goes all the way back to the slave narratives and folklore and all of that. I think that what we will have now in terms of reproductive health, and I won't limit the focus in terms of abortion, but when we talk about reproductive health, we also have to think in terms of, if these stories are told, they can easily be dismissed and not acknowledged. And therein lies the problem that we actually would have, is that, so if they can be easily dismissed, that means that we go back to the control issue, which historically in this country focuses on women as second-class citizens. So of course that's women in general, but then once you focus on actual race itself, when it comes to Black women, it's even worse. So I think that that's definitely a point that we have to keep in mind. Also, in terms of the maternal health and maternal health, we also have to be mindful of the class issue, because even though abortion is being taken away as a right for women in certain states, we also have to be mindful that if you are within a certain class, you actually have the ability to go to some of these other states, similar to what happened in Indiana and Ohio a week ago. You actually have the financial capability to actually go to these other states. So I think the challenge that we have to be mindful of, and the challenge for all of us that's here in this session, is how do we actually inform the people in our inner circle, and we actually be that pendulum, be that person that actually connects these different stories and these issues so that people are aware. Because one of the biggest topics that's not discussed often in education, and especially at the K through 12 level now, considering how a lot of states are taking away even the discussion of abortion, birth control, and all of that. What I would challenge everybody in this session to do is, what are you going to say to the next person that you see after this session about this issue? Because Black women's health is a major challenge in this country. They are not respected, they're not appreciated, and then their voices are not heard. So we have to actually ask ourselves, especially for me, my research focuses on Black women in popular culture, and I make sure that I always inform my students about what's actually going on. And it is not limited to Black women, because if we limit the focus to just Black women, we are missing it altogether. So that's just my comment on everything that has been discussed so far.
Thank you very much, Christopher. Very, very, very interesting points you make. So thank you very much for that. Anyone wish to comment based on what Christopher just said? He said a lot in this short space of time. Dr. Ferdinand, you're welcome. Dr. Cummings, you're also welcome. And anyone else in the audience, you're also welcome to comment on his remarks. Thank you.
I know the things that I can do, and I've thought long and hard about this, you know, as the chair of African American Studies. Next year, I'm hoping to put on an entire program for Black women and girls. So just facing all the issues that affect Black women and girls. You know, we're looking at Black Transgender Day of Remembrance, Afro-Latina Day, like all of that. And we're trying to put together programs and events. And I could certainly share it with Natalia when I have a running list, but my focus next year is to highlight some of these issues and these concerns. That's because that's in my purview. I can do those kind of things like that. I can also do things like create courses. I'm working on interdisciplinary courses, one on Black girlhood studies, one on Black motherhood studies. So, you know, I'm trying to like educate the people that are coming behind me, and so that they can see, they can learn about these issues, you know, although I know, you know, they may not learn about it through K through 12 education, like what Dr. Jackson was saying. I feel it's my responsibility that once they arrive at City Tech and they're freshmen, I have a responsibility right there. So I feel like, you know, that's me picking up the torch and saying, okay, you didn't know this before, but you're going to know it now. And so those are just some of the things. I would love to collaborate with any of you guys here, you know, some of the programming as well too. So I'll be in contact about that.
Thank you very much, Dr. Ferdinand. Dr. Cummings, do you want to weigh in?
I would love to, and I completely agree with the remarks that, you know, that have been said. One of the things, I think that that's all kind of why we're here, is that we are all wanting to be part of the solution. And I think that, you know, forums like this where we kind of get each other thinking and, you know, brainstorming about what can we do. I agree that teaching and education is a huge part of making sure and telling our stories. Like, you know, part of what I try to maintain in my practice is I'm always working with medical students and residents and teaching. And I think it's important for them to see a woman of color in that position, you know, trying to, you know, I'm not the chair of a department yet, Dr. Ferdinand, but I'm going to hustle up and try to get my promotion to associate professor, but also to help with solutions in the community. So one of the things, and I am not spearheading this, but I'm helping my colleague, Dr. Audrey McDougall at Cornell, has a program called the Embrace program, where they're literally trying to pair doulas with birthing patients, because there's a lot of research that shows that if a patient has a doula, they have better healthcare outcomes. And there's money that New York State has, you know, given so that we can connect these women, because you go to your prenatal appointment, you know, once every 1 to 4 weeks, you see your doctor for like 15 minutes, maybe you get a couple of ultrasounds. If you're not plugged into some other system, either your own family or like a mom group, there are a lot of people who are out there getting their prenatal care and they're totally alone and they have no idea what they were doing. I really appreciated Dr. Ferdinand. I was laughing because I was thinking about how when I had my kid and, you know, trying to get it together as a physician and a mother, and it was often very interesting, you know. But we have a lot more access. You know, there are people who just don't even know what they don't know. So having a program like the Embrace program, where we can begin to connect the patients to doulas who can give them another resource and literally improve their health outcome, because that's a resource for that patient. So for all of us to, you know, to keep this conversation going and, you know, try to find more solutions like that. I think that's amazing.
Thank you very much, Dr. Cummings. Ms. Greta Strong, I see you had your hand up. Thank you so much for being so patient. Thank you.
That's fine. I'm Dr. Greta Strong, and I am an assistant professor of community outreach teaching here at Weill Cornell Medicine. I'm a colleague of Dr. Cummings. And Renatta, please reach out to me if you should need any help on any issue, especially women issues. We also have women neurological issues that we can deal with, because I am in the Department of Neurology, but I have been here for 26 years and I am firmly grounded in community outreach. So please feel free to check in with me at any time. And Natalia can give you all of my information.
Wonderful. Thank you. Thank you, Dr. Strong. I sure will.
Dr. Strong, let me apologize. I didn't add your title. I'm so sorry, Dr. Greta Strong.
No, that's quite all right. And Renatta also know that I am alumni from MCNY, and I'm also an adjunct, and I have been teaching there for 19 years.
Thank you. Wilhelmina, you have a question? Can you come on? Thank you.
Hi, so I have a question for Dr. Cummings. I have two questions for her. My first question is gonna be, can you please tell us about your work and your journey in relation to Black maternity health? And the second question is gonna be, how was the personal, political, and professional comes together for you?
Let me unmute myself. Those are two excellent questions, Wilhelmina. Thank you. So I think I'll start with the first one, which is, how, what has my work been in the Black maternal health? And it comes in several different, portions, I guess is the best way to say it. And one is literally just being a doctor and taking care of women of color. And it's, it's probably not a surprise to anybody, but a lot of women of color or birthing people of color will seek out a provider of color. There's clear research that shows, and that's not always possible because there's not enough of us, but there's clear research that shows that there's a slight decrease. For example, the paper I read, there's decreased infant mortality if the infant's taken care of by a doctor of color, which again, it's very hard to, there's a lot that goes into that, so I'm by no means suggesting that's the only way to do things, but I think that just literally taking care of people in my community is thing one, you know what I mean? And just being there. And it sounds like that's simple, but it's not. I was at Mount Sinai for 18 and a half years, because I've been at Cornell for a year and a half. And I made it a point to stay in Upper Manhattan because I knew that I was the only one who was there. And even when it became difficult because I didn't have other doctors in my office, and that there a lot of political stuff and the takeover from a different hospital and everything, I made it a point to stay in that neighborhood because I felt a duty to my community. And then the other thing that I think not just myself, but a lot of the doctors in my new current home of Weill Cornell is we are constantly doing research. I give talks to medical student groups, to other physician groups about not just maternal, mortality in the communities of color, but all topics, just to kind of raise awareness of the health issues that we're facing and to be visible so that they can see that there are people of color, in the community, we're doing our thing. Wilhelmina, remind me the second part of your question.
Okay, so the second part of my question is, how does the personal, political, and professional comes together for you?
That's an excellent question. I think that I feel lucky to live in New York City. I'll start with that. I don't know what life would be like if I lived somewhere else, because I definitely came into OBGYN being, feeling like I am a feminist, and I have always been very passionate about reproductive rights. And I think that that's something that makes sense in my life, and I have people around me who are supportive of that. But I do worry, like we all have family in different states, and I worry about my Texas family, and hope that I have a niece who lives there. I worry that her life and health could be impacted by this, So, I mean, I'm lucky because I live in a place where I have a lot of like-minded people around me who are very supportive of me. And you know, a kid that is probably not going to go into medicine, but, you know, knows all kinds of things, you know. And just like Dr. Ferdinand knows, he's positive he knows more than I do. But I think that it's always a hard thing, and any of us who's parenting while working knows that that's not an easy lift, you know. But I think that we inspire our kiddos by just, you know, by continuing to do what we care about, what we're passionate about. And I think that literally living and doing your thing and letting the world see you do it is a statement in and of itself.
Okay, thank you so much, Dr. Cummings.
Michelle, I see you have your hand up. Can you come in?
Yes. So my question is how, and this is for Dr. Cummings and Dr. Ferdinand. My question is, how do you incorporate mental health into your work? Because as we know, there is a whole lot of trauma behind what's going on. So how do you incorporate mental health? How would you incorporate, if not?
Dr. Ferdinand, should I go ahead and start?
Yes.
Okay, so I would say that is such a great question, and it's you know, again, it's yet another one of these things where our community doesn't get enough of what it needs, you know. Postpartum depression is a hugely common phenomenon. Depression in general is very common, and just like you said, you know, being a person of color, like through the pandemic and being, you know, disproportionately affected, and the, you know, not even beginning with, but, you know, kind of George Floyd, everything that we're having to live through is traumatizing to everybody. And I think that just acknowledging, for me, it comes in acknowledging my patient's feelings and needs and making sure that we ask the question, because it sounds like it's a simple thing, but you've got a lot of different pressures on you to move the patients in and make sure that you've, you know, done all this busy work and all this kind of stuff, but you can't forget to actually make sure that your patient's mental health is being tended to. And the only good thing I can think of from, you know, in terms of like healthcare versus like telemedicine, the one good thing that has come out is that you can actually somewhat more easily get therapy for your patients, because there's a lot of online platforms that it is easier for the working mom who, you know, has a kid or two or three and can't really leave to go see a therapist who in New York is going to be a cash only therapist who's going to charge you God only knows how much, you know. So now we can at least try to connect this woman to therapy that takes her insurance. It can be done online. It's easier and it's more reasonable. So that's where I begin with that, is to just try to make sure I talk to everybody and give them their time and hook them up with therapy and try to destigmatize it.
Thank you.
I think for me, you know, I write about it. So I've written about when I've had postpartum depression. I've written about when I've had a miscarriage. I've written about the differences between who I am. Let's say I call my alter ego Pinky. So I have an alter ego, and I just wrote a piece about this alter ego Pinky, who is free and says anything she wants, does anything she wants. And then there's the Renatta. So I write about like a lot of my own mental health challenges or any kind of challenges that I faced. And in the autoethnography, one of the reasons why they can be very difficult to write is because they pull from you those things that you wouldn't tell anyone. Or, you know, it makes you put in words what you're feeling emotionally. And so sometimes words can't fully grasp it. And so even sometimes when it can't fully grasp it, I'll write in, like I wrote in my book, fuck. Like there are lines, damn, in my book, because I couldn't find another proper word to express how I felt about it. So I think by me writing about it, it has been therapeutic. Like, especially like when I had postpartum depression, to write about what that felt like. Cause I felt like, I think in the chapter, I said it was like Alice in Wonderland. Like I had dropped down in a hole and I couldn't figure my way back up. And so I think that has been like my contribution of writing about these things. Me and my daughter, we just actually wrote a piece, and it's out now. It's called Black Women, Black Girls, and the COVID-19 Pandemic. And so I write in my voice and she writes in her voice. And it kind of talks about the mental challenges we faced during COVID-19. and we related our experience to the plight of Black women during COVID-19. And so I think all of those kind of things and writing about it and putting it out there, for others, that has been like a way for me to address my own mental challenges.
Okay, great. You said, you mentioned that you just wrote the book. Is it out now?
With the autoethnography?
Yeah.
The autoethnography of African-American.
Yeah, the part about the mental health, that's in the book that you previously wrote.
Yeah, that was in a collection about childbirth and things like that. The most recent one that my daughter and I wrote, that's in a journal called Cultural Studies Critical Methodologies.
Okay.
And that's about Black women and Black girls.
Is it out?
We've shared that, Michelle, and I'll send it to all around to you guys again.
Okay.
Dr. Allegra Cummings, I see you have your hand up.
Thank you. I just was so, I'm having such a great time doing this panel with Dr. Ferdinand. This is fantastic. Thank you, Dr. Ferdinand.
Thank you.
I wanted to give you a shout and a cheer for talking so I'm clearly going to have to read your book now. So I want to give you a shout out for, I just love how you're sharing your personal stories. And one of the things I think that's so important for, women, birthing people of color, we need our stories out there. Previously, we're talking about, we don't want to get forgotten. We don't want to get dismissed. And it's so important for us to have our stories out for each other to read. Like one of the things that that hit me was when you were talking about having a miscarriage. I have so many patients who miscarriage is very common, and people, it's almost like, in the 50s when people wouldn't say cancer, they would cancer, like the C word, like that, it's, you just didn't talk about it in polite society. And miscarriage is like that now, which is terrible, because we, more than ever, we need to be sharing with each other and talking about it. And I just wanted to say thank you for that. I think that if we have more of us telling our stories and getting the word out, it's going to help people, get through this crisis that we're in.
Thank you. Thank you so much.
Thank you, Dr. Cummings. Tamika, your hand is up.
Yes, I first just want to say I commend Dr. Ferdinand as well on being able to talk to her daughter about a lot of things, because one of the most important things that I want to say as being a Black female and I know I look a little young, but I'm a little older, and my mom, when I was younger, she didn't talk to me about things. Like I remember asking her, well, you want to talk to me about my period? And she was like, oh, they're going to tell you about it in school or whatever. I'm like, okay. A lot of things we don't share with our kids, or we don't share with other people. And one of the things I heard somebody say, I think it was the Dr. Cummings, or talking about VBAC, or birth after cesarean. And I know about that because, I experienced it. Another thing that I experienced as a Black woman is involving fibroids, and something that I found out was like really common in Black women, but I didn't know it until I went to a doctor, and the doctor told me, and the first thing they wanted to do was, oh, we'll give you a hysterectomy. I'm like, hysterectomy? Wait a minute, I mean, you're gonna take my body parts? Like, I was feeling like if I didn't need them, God wouldn't have given them to me. So, just being skeptical and like scared. Plus, I was seeing a Caucasian male doctor, and it's like, I think I need a second opinion because I don't know, and another thing, I couldn't talk to my mom about it. I don't know if she ever experienced it, or, so I have to be able to talk to my peers, or once experiencing something, or, personally, then that's when we start to do the research. Like a lot of things we don't know, and we don't even look into them until they happen to us personally. So, yeah, I think all of this is good and important, and I just wanted to say that.
Thank you, Tamiko. And you made me a little bit emotional because you brought up the idea that your parents or your mother didn't educate you on a lot of things. And I share the same sentiment. Being born and raised in the Caribbean, our parents have this idea that they shouldn't talk to their girl children about certain things as it relates to sex and reproductive health, etc. And something else you mentioned that again really touched my soul is the issue of uterine fibroids. It's a reproductive health issue I'm very passionate about, which actually drive me to create my own initiative and awareness page, because 12 years ago I had uterine fibroids. And it's just overwhelming to know that a lot of women out there still doesn't know what uterine fibroids are. They don't know the signs and the symptoms. And that is what really compelled me to actually become a health educator, and more so to use my own personal journey with uterine fibroids to give back and to actually help other women who might be going through the symptoms and don't know what it is. For example, something as simple as a heavy menstrual flow. Most women think that that's normal. I'm supposed to have this heavy flow that's normal, when the truth is it's not normal. So again, I think Dr. Cummings or Dr. Ferdinand had mentioned the importance of education. And I just wanted to say, Tamiko, thank you so much for sharing this point. Thank you so much.
I have a question for Dr. Cummings. Just even on that note, Dr. Cummings, do you see a lot of Black women in your practice with uterine fibroids?
I do. I see a lot. And it is, it's interesting because we live in a world where, until just recently, most doctors were men and probably were Caucasian men. And, even my mother, when she was, pregnant with me and my brother, and had some tiny little fibroid, and they were like, oh, well, you could get a hysterectomy. She's like, it's not bothering me. Why don't I need a hysterectomy? I have a ton of patients with fibroids, and we have a lot of, so again, it comes down to really talking to your patient or to your doctor. This is the education piece of things, and making sure that you're finding out, how are your cycles when you do an exam, like, do you feel the fibroids? I am always very liberal about sending people for ultrasounds because it's an inexpensive test, and fibroids are super common, especially in women of color, but it doesn't mean that you need a hysterectomy. There's so many different, there's a billion different things you can do, and there's different treatments, there are different options, and sometimes what is right for you at one stage in life, 5-10 years down the road, it might change for you, but there's always options. So I think it's very important to make sure that people know what it is. I'm big on education. I pull up charts and send my patients all, they probably get sick of me because I'm always sending them just more and more, here's your patient education stuff, but I sit and I go through it with them because it's important that what's happening inside your body. I think that again, circling back to what's going on with Roe v. Wade in certain states, trying to get in between educating our young folks about, sex education and health, because the sex education, again, isn't all about wear a condom and take birth control. Some of it is about, if you have super heavy periods, that's not normal. If you're pregnant and you're having extreme pain, that could be an ectopic. Like there's stuff that our education system needs to go forward and not backward. So yeah, thank you, Dr. Ferdinand. That was a great question.
Is there any more questions for our guest panelists? Feel free to weigh in. Is there any more questions?
I have a question, actually. My question is, in hearing all of this talk about health education and different measures for addressing racism, and then storytelling, and also just actually in helping to support this initiative and focusing on these issues that are very depressing. The numbers are depressing, right? The reality that this is being caused by racism is depressing. And I know often I'll send things, and Cabrina, for example, will say, oh, that was too much, right? And I wonder, I feel like it's an important conversation to have. how do you find the balance? I mean, this is a little bit related to the mental health question, I think. How do you find the balance between having the conversation be eye-opening and energizing and activating, and it causing more stress, it putting more pressure on the patient of color? How this is an open question for both our guests and for anyone else to weigh in on.
I think I'm going to, for my part, I'll answer your question with there's an article I found by Dr. Erica Cahill and Erica Chidi, who's a doula in California. And they wrote a piece called Protecting Your Birth. And that it was when I began my whole academic journey into trying to look at what are the factors that are, yes, racism is definitely at the core of it, but how does it ripple out and how is it causing disproportionate health outcomes? I found their piece, and it was literally like a guide on how women of color could begin to talk to their healthcare providers about the fact that they have a higher chance of dying in childbirth than their, non-Black or, counterparts. And it was fascinating to me because I've had so many patients come in. It's like when you are putting your kid to bed and the last thing they ask you is the most important thing they're going to ask you. It's like when I've got one toe out of the door, the poor lady is like, but doc, how am I going to not die in childbirth? And that's the thing that they've been keeping in there. And it's gut-wrenching, honestly. It's gut-wrenching. You've got this young couple and they're so excited and so cute, and they want to be happy and enjoy, but they're also terrified, And so I tell them about this article, and it's brilliant because it basically, one of the first things that they said is make sure that you acknowledge that race and racism are in the room, and then go through try to get if you feel like you need a doula, have open conversations about what are the things I should be concerned about, doc? Like, should I, make sure that the patient feels like that they have an advocate not just in you as their healthcare provider, but in other resources if it's necessary. I have actually gotten a lot of people into writing birth plans so that it's almost like, and it seems kind of silly, but kind of putting down on paper, these are the things that I am hoping and wishing for my birth, because it gives the other care team members just a minute to kind of pause and think about that birth process for that patient. So it can definitely, I agree, it can definitely begin to kind of kind of drag you down. But what I try to do is with a lot of this stuff, acknowledging it, once you've said it begins, when you're keeping something down and it's trapped and you're not talking about it, it always festers. Like if you are able to get it out and say it, we begin to be able to look at that. And maybe we're not going to get to perfect in my lifetime, but we're going to try, and we're going to come up with solutions. So that's kind of how I approach it.
Thank you.
Yeah, and I think also one way that I try to approach it, like sometimes I read something and it'll be so terrible and it'll sit in my body. Like I would feel it, like I would be like, oh, I hate what I'm reading. I remember one difficult essay that I wrote, and it's in cultural studies, critical methodologies as well. It's called Remember Me. And so in this essay, I was trying to connect Black women from the past and some of the experiences and challenges that Black women faced in the past, and say that this is the same experience and challenge we're facing now. And it sounded like it was going to be easy to do, but I had to go back and look at the challenges. And so when I'm going back and I'm reading about Hottentot Venus and her being on display at the Museum of Man in Paris, and I'm reading about these statistics of the eugenics program, all of that kind of stuff. And I got angry. And then I said, I don't want to write this paper. So I stepped away from it. Then I came back to it. I might have stepped away from it for like 2 weeks because I just hated what I was reading. I sat at the computer and I didn't know how to start it because I hated what I was reading. And so it was a mental challenge to write this paper. And so what I ended up doing in the first line in the paper is, I hate this paper, because that was the truth. And so when I started, I hate this paper. And then I told the audience why I hated it. And it was everything that I had learned about Black women in the past and what was happening to Black women now that made me hate it. And so I had to say that, and autoethnography allowed me to say that. So I think for me, it has been like a challenge. Like when I read all this doom and gloom and, oh, this is happening, it sits with me, and it's a process.
So it's almost like making it a story, a real story, making it the real story, which is what you do in your work, like putting in the research and connecting it, but more than connecting it to your life, just sort of showing how it plays in your life.
Yes.
That's part of the reason the storytelling is so important.
Yes,
in
yes.
general for this.
Yes, you got to connect it, because if you connect it across time and space, you'll see that it's the same issue, right? So this may be happening to Black women right now. It takes this form, but this happened 100 years ago, and it took that form. So, you know, when they don't believe Black women, when a lot of medical students don't believe that Black women are experiencing pain, that didn't originate in 2022, right? So we know that was 100 years ago when Dr. Sims was performing those gynecological exams without anesthesia. So we see the manifestation of these things 100 years ago as well as today.
Absolutely.
Miss Tina, I can tell that you want to weigh in a bit. You're welcome.
No, I did weigh in. I've been putting all that stuff in the chat.
Okay. I didn't mean to put you on the spot,
That's
but I read your
that's
face.
why I forgot when I was doing my introduction to say that I would be putting all sorts of resources in the chat as we go along in conversation. So that's why I've been quiet.
Oh, okay then, thank
But
you.
you also read my mind, Lorna, because I was like, I'm being very quiet. But when we have our little personal discussions every Tuesday, I be running my mouth like a storm.
I read your face and I had to call on you.
But anyway, I put a lot of the resources based on our conversation within the chat. So it's available there, articles, the actual aftershock, and the interviews with Tanya Lewis Lee, etc. All about that. That's in the chat also. Dr. Ferdinand, your book, which we also have as part of our collection. So if anyone that goes to MCNY is interested in getting here before somebody else to borrow the book, it's available, etc., etc. Okay.
Thank you. Thank you so much.
You're welcome.
Thank you, Tina. At this point, I would like to call on our peer leader, Cabrina.
Hey everyone, I'm Cabrina, and I would just like to do a wrap up for the whole group as one, because this is something we all have been looking forward to, and we meet up every Tuesday just to get the tea. So we have got a lot of tea in this discussion, and we are very, very thankful for our guests, our two doctors, our two sisters, Dr. Cummings and Dr. Ferdinand. I also want to give a special shout out to our guests, Christopher and Tamika as well. Thank you for like really chiming in, because the things that you said as well definitely is something that us as a group, peer leaders as a group, we look into that. We want to know questions about that. So we thank you for your intake, and the other guests as well. This is definitely a lot, but I would like to say from Dr. Cummings, your transparency on the transgender process and just the whole GYN as a doctor, like you there in person. I work in the hospital too. I'm a medical assistant in the interventional radiology department. I don't do too much there. I just do a little inventory, but just being in the setting, I know what it is to be there and see the difference. So I'm thankful that you're there and you doing the most that you can do. And to Dr. Fernandez, I would just like to point out to you, and I know as a group, we are very thankful for your
We're gonna work
we
on that
very-
tomorrow.
Yes, we're gonna work on it.
Everybody's gonna have to say it 3 times.
But we are very thankful for that, especially me, because I'm like I said, like I'm in the field, but clinically, like I tried it out. That's not really my thing. But however, I still want to be there for my people. So that's why I stay where I'm at, so I can be as much as a resource. But yeah, just I like to write too. So journalism is something for me. So I'm very thankful that you shared today how our stories mean something, because your story mean a lot. So thank you.
Thank you.
And yes, Dr. Strong as well. Thank you, because she prepped me for this before we have spoke all together as a group. And this will hopefully, for our next roundtable, give us more topics and discussions to look into, because I want to point out as well as a group, guys. So check this out, y'all. Christopher said it's not only about the Black like people. It's as a like he teaches Black woman and all that, but he teaching the other woman. Yeah, he teaching other women about our like us. And I think that's real dope, because even working in the hospital, I feel like doctors or whoever, everybody should have like a class on the different ethnicities and cultures, and so it makes it's not, we're not saying, oh, pro-Black. Well, yeah, we are saying pro-Black, but we not like that, and we want to spread awareness to everybody. So I appreciate him for definitely chiming in, and keep doing what you're doing, brother, because we respect it coming from a Black man. But yes, and that is my peer leader wrap up. Thank you.
Sabrina, you couldn't have said it any better. Thank you so much. And at this juncture, I would like to say a heartfelt thank you to all of our guest panelists, Dr. Renatta, Ferdinand, Dr. Allegra Cummings, Dr. Strong, and also to our peer leaders. And last but not least, also to our audience. Thank you guys so much for being a part of this second roundtable. The information that you all presented here today will go a very long way. So on behalf of the peer leader group at MCNY, I would like to extend a heartfelt thank you. And also I would like to just put the word out there for us to be in contact, right? Please be in contact if there's any way we can volunteer in whatever project that you're doing. I know for sure I'm all fired up to be a part, and I'm pretty sure others are as well. So thank you all so much. And we look forward to meeting with you all in the future. Thank you so much.
Thank you. Thank you, Lorna. I just want, thank you so much. This was so wonderful to have you all here, and peer leaders, you were just great. I put a link in a feedback form. If our guests could please open that up. Also, I'm going to be copying the chat so that we can save all the resources that we put together, and we can send them out to you. Yeah, I just wanted to say that. Thank you.